As the science of breast augmentation evolves, our decisions in how we do these surgeries evolves too. It used to be dual planing implants was considered to be the gold standard. Dual plane 1, dual plane 2, very rarely dual plane 3. Interestingly, at this aesthetics meeting, one of the leading experts in the field, one of the podium speakers, was like, I almost never dual plane my patients anymore. They feel that they were getting more breast animation. That is, when patients flex their pectoralis muscles, how the breast will change shape. And they didn't feel like the dual planing was helping in terms of overall results. So that patient was using a technique where pretty much the muscle was completely intact. And so you're not allowing that muscle to retract up over the implant. Another speaker got on the podium and was almost 100% of the time putting the implant in front of the muscle. And then another lecturer said the same thing, that they were trying to put implants in front of the muscle as often as possible. They both said that in those situations, the skin isn't quite as able to hold the implant in the right position as the muscle is. And so they were using mesh for those breast augmentations. So if you asked 5 different plastic surgeons in town their preferred way to put an implant in, I bet you would get 5 different answers, because it's always changing and it's always evolving. And a lot of it has to do with personal experience and seeing patients over time. And so lots of times patients come in with lots of questions regarding those things: above the muscle, below the muscle, where's the incision going to be? Am I going to use gel implants? Am I going to use saline implants? And hopefully in the course of a good breast augmentation consultation, you're going through all of that data, all of that information, and coming up with a really solid plan for your patients. But everybody's different and everybody gets a different plan. My thoughts about breast augmentation have evolved, and I am definitely putting more implants above the muscle than I used to. I put it actually underneath the muscle fascia. So this is what we would call subfascial breast augmentation, where you leave the muscle down, muscle's undisturbed. So patients can exercise, use their arms, do push-ups, do bench presses, rock climb, all the activities that patients like to do. And the fascia goes above the muscle. That gives a little bit more protection and camouflage for the implant. And it also separates the implant from the breast tissue, because there's some thought that the breast tissue, that the glandular tissue in the breast can lead to, when that's in contact with an implant, can lead to higher capsular contracture rates. So using that barrier, the fascia between the breast implant and the breast, but leaving the muscle down, you kind of tend to get the best of both worlds. You're getting no muscle animation and no muscle pain when you use the muscle, but you're getting protection for the implant. The caveat there is for my very slender patients, they might not have enough tissue to camouflage the implant adequately. That is, you have to have kind of a natural B cup or larger to have enough breast tissue so that when you put the implant above the muscle, you don't see the implant. You're not seeing rippling or the edges of the implant. For those natural A cup breasts, very slender, very thin patients, those are situations where I'll still go under the muscle. Most patients are very happy ultimately with their augmentation, really no matter where you're putting the implant. But I think a well thought out plan and a well executed plan leads to patients being happy with their results. And that's where part of that conversation has to happen. So in my practice, it's probably 2/3 of the time I'm above the muscle and 1/3 of the time under. Yeah.